Okay, thank you. It's a honor to be here and participate in this symposium. My charge was to talk about leadless pacing. I actually thought it was to talk about all extravascular devices, so I'm going to have to cut it off short so I don't horn in on Dr. Cayley there. Just to start a little bit, which one of these is on here? There's my disclosures. So there's about 1.5 million implants, CIED implants globally every year. In the United States, there's about 200,000 permanent pacemakers and 120,000 defibrillators. So as you know, the population gets older and we're being more aggressive with older and sicker people that drug therapy and are keeping alive longer. We're putting them in this device in sicker, more complex patients. All right, so of all these devices that are put in, most of them require permanent venous access. And so I like to think of it as, if you're worried about somebody's venous access, either they don't have venous access, they don't want venous access, or venous access puts them at increased risk of some other of a lead complication. So what are some of these? Except I went the wrong way. All right, so what are some of these conditions? Well, obviously renal failure, where you want to preserve venous access in these patients, plus these patients obviously are subject to ongoing transient bacteremias from access all the time. If you have known, obviously subclavian or SVC occlusion. If they've had chest radiation, I've seen this a lot. I used to do a lot of MD Anderson stuff, and the veins in patients that have had chest radiation are frequently very small. Sometimes they're occluded. Complex congenital abnormalities. These people are prone to bacteremias, and also their anatomy is off. Artificial heart valves, where you want to limit venous access because of bacteremia issues. Hobbies, cosmetic issues. If they've had multiple previous accesses from cancer or cancer treatment. And then, of course, people that are on immunosuppressants. All right, so what are the problems that we see then with leads and devices? Well, about 8% of patients at 5 years will have a complication related to the device pocket, either infection, hematoma, erosion, chronic pain, or it's sticking out and they don't like it and they want you to do something about it. Lead-related complications are higher at 5 years, 11%, lead fracture, insulation breach, venous thrombosis, tricuspid regurgitation, and of course, lead endocarditis. And all these things are seen more frequently in younger patients. All right, so if we want to not use the veins, what are our options? Well, we can go just straight epicardial for both pacing and defibrillation. We can do subcutaneous for defibrillation. We can do extravascular for both defibrillation and some limited pacing. We can do intracardiac for pacing, or we can do a combination for pacing and defibrillation. All right, so what about the epicardial approach? Nobody wants to do this, obviously. Operative morbidity, discomfort. The other problem with epicardial leads is that they aren't reliable long term. They tend to have high thresholds, and they're more prone to lead fractures over shorter periods of time than endocardial systems. All right, so the concept of intracardiac pacing goes back a long time. This is an article from 1970 where this physician had the idea of putting a pacemaker on a stick and putting it in the right ventricle. He envisioned a nuclear-powered battery that he delivered via this stick. And you can see it kind of looks a little bit like he probably ought to sue Medtronic, actually. It looks it looks pretty close to the current micro device. But obviously, if you're going to do this, you have to be able to have deep miniaturization. It has to be deliverable in a safe and reliable manner, and it has to have some preserved functionality. All right, so these are the systems that we have now, the Medtronic Micro on the left, and then this is actually the first generation of Abbott NanoStem. It's now the Avere, which is a little bit shorter than that, actually. And these devices are small. That Medtronic one looks like one of those big kind of vitamin pills. So the device itself is about 2.5 centimeters long. It's 20 French width, and the volume of it is less than 1 cc. It's capable of VVIR pacing. It has bipolar sensing. You can see the distal electrode here is the cathode, and then the anode is back here about 2 centimeters. So the interelectrode spacing is about 2 centimeters. It's MRI compatible. It's bipolar sensing and pacing. It has capture management, rate response. It has limited diagnostics. It will tell you about the battery, about the threshold. It'll tell you impedance. It'll tell you percent paced. But it doesn't give you too much in terms of diagnostics, because that chews up memory, and of course the battery is obviously small. You can turn it off, and it will turn off automatically when it reaches the end of service. All right, so the system itself is composed, obviously, of the pacemaker, the delivery system, and the introducer sheath. The delivery catheter is 105 centimeters. It's a pretty simple system. It's got a deflectable tip, and then you deliver it by releasing the capsule, and it's tethered at the end, so you can recapture it and reposition it. The introducer is large. It's 27 outer diameter, 23 French inner diameter, and a 56 centimeter length. It's very slippery and slips in the vein very easily. Okay. All right, so the Medtronic version of this is a passive fixation. So it's got the nitinol fixation mechanism that does not in contact with where the cathode is in contact. You can see here on the left is just a typical active fixation electrode, and as you know, the fixation mechanism is the distal electrode. So what happens is you get fibrous tissue around where you interface with the myocardium from trauma from the screw. And of course, this leads to higher thresholds and reduced battery longevity. This is a removed micra from a pig, and you can see that the tissue where the cathode interacts is not part of the fixation mechanism, and there's no fibrous tissue. So what that allows then is very nice capture thresholds for improved battery longevity. All right. So how is the longevity of this device? It basically, even though it's that small size, it's at the same longevity as the other Medtronic devices. These other devices, nowadays 95%, 98% of leads are active fixation. Non-coronary sinus leads are active fixation. And so that the battery, because of these low thresholds, the battery longevity is the same. So, sorry, this video is not working, but it's very actually straightforward implant procedure where you just deflect the delivery catheter through the tricuspid valve, advance it to the intravesicular septum, and release the device. You know, a lot of people feel it's important to go to the LAO view and confirm that your device is septal and not anterior. You can also tell this in the RAO view by there being a little, it's called a RAO, in the RAO, a little space between where the catheter is and the heart border. So you deploy the device. I mean, I think an example, to me, this looks a little bit more apical than you would want to be, but this is actually on the apical septum, but you don't want to be, as we found out, you don't want to be in the apex, as we'll see in a moment. The IDE trial, which we participated in here at St. Luke's, which led to the approval of the micro device, was a non-randomized trial of 725 patients, for 94 implanters all across the United States and across the world, in patients that met VVIR implantation criteria. This was compared to 2,600 patients that used standard commercially available pacing systems. So what were the results? There was 96% freedom from major complications at 12 months. If you did have a complication, most of them occurred within an implant or within the first 30 days. There were a spattering of events that occurred from 30 days to 6 months and rare after 6 months. I think importantly, they had 0 dislodgements and 0 infections. Pacing thresholds remained low and were stable at 12 months follow-up. Estimated battery longevity in this study was 12 years. So what were the complications? Well, the most common complication was cardiac perforation, which occurred in 10 patients at implant. There was one late, I think, late effusion at a month. So most of this, actually, if you look at pericardial perforation and effusions, they're more common with standard pacemaker implantation than they are with micro. However, the perforation that occurs with micro implant is a much different disease. It's much more likely to have to go to the operating room. The holes are much bigger, and the event is a much bigger deal. And this, in the initial study, this was predominantly related to putting it in the apex. When we first started this study, they told us to put the micro the first choice was to put it in the right ventricular apex, which is thin and which led to most of these perforations. In fact, the first implant that I did was one of those 10 that perforated. We stuck it in the RV apex in an elderly man, and he perforated. We didn't have to go to surgery, but we did have to tap him. Nowadays that we've gotten away from the apex, that incidence, as we'll see in a second, is much less. Median implant time was 28 minutes, introducer in to introducer out, and that was in guys that were just in implanters that were just doing their first implants. Now it's usually about a 20-minute procedure, faster than a VVI pacemaker. The septal placement of the device has led to significantly lower perforation rates. In the IDE trial, the perforation rate was 1.8%, and in the post-approval registry, it had dropped to 0.8%. And even in that study, 32% of them were in the apex, and I think all but one of those perforations were apical. So, as we said, the micro has rate response parameters, and so the accelerometer in the Medtronic device obviously senses body movements and increases the rate accordingly. It also senses events in the heart. So when the mitral valve closes, when the mitral valve opens, that causes changes in blood flow, which that sensor can detect. So on the top here, we have the surface electrocardiogram, and the bottom two are the accelerometer recordings, the raw one in the middle, and then the filtered one on the bottom. And you can see this A1 is mitral and tricuspid valve closure, and then we have systole, and then we have A2, which is aortic and pulmonic valves closure, and then we have A3, which corresponds to the E wave on echo, which is passive filling of the right ventricle, and then we have A4, which is atrial systole. And you can see it's about 100 milliseconds delay between the surface electrical depolarization and the mechanical A4 in the right ventricle. So this device then can sense what A4 is and then track it with pacing in the ventricle. So we now have second generations of Micra, the VR2 and AV2, and basically these have a little bit more enhanced battery longevity, also in terms of the AV2, it's got improved tracking of A4, and it does it automatically now. There's also a new catheter design which allows for decreased tip pressure, which hopefully will reduce complications rates, specifically pericardial effusion. You can put this in through the neck. I don't recommend it be your first one, but it's actually pretty easy because it just comes right around onto the septum. And obviously, anybody that you can't get up through the leg or this tortuous, it's very short route from there to the RV septum. So the other major company, which is the Abbott Avere device, is a little bit more like a cigarette. It's shorter and narrow. 38, I mean, it's longer, 38 millimeters, and narrower. It's similar implant technique. The handle is a little more complicated because this device is active fixation, although the electrode is not part of the active fixation mechanism. It's got a little bit more of a learning curve to it. The handle is just kind of busy. But still, it's pretty straightforward. The good thing about the Avere system is that it's readily achievable because it's active fixation. There's a retrieval catheter that they have, and in this, and the company's data, 88% of chronic retrievals were successful at 5 years. 92%, pardon me, predicted retrieval rate at 5 years. The Avere system is now available in a dual chamber where you can, the atrial device is smaller than the ventricular device, a little shorter, it's the same diameter, and this is screwed into the base of the right atrial appendage. It's 98% successful implant, 95% of the time you can maintain AV synchrony. This entails communication by subthreshold pulses between the atrial device and the ventricular device. And 90% of the patients had acceptable atrial pacing capture and sensing at 18 months. Micra versus Avere, they're obviously similar devices. The Medtronic device does have capture management. It does have remote monitoring. You cannot map, with the Medtronic device, you just implant it, and then you hope your thresholds are good, which they usually are. With the Avere device, you can map and make sure you have adequate pacing and sensing thresholds. So I'm going to skip through this because this is Dr. Kalu's stuff. I thought I was supposed to do it. And I'm just going to buzz to the future. This study has actually been completed. So this is what we've all been sort of waiting for, where you have a subcutaneous device that communicates with an intracardiac device. And this is a Boston system. You implant the micro-like device in the right ventricle, and then it communicates with the subcutaneous pulse generator. So you have ATP, you have backup pacing, and yet you have external defibrillation, and you do not access the veins. This study has been completed. It's major complication free of over 97%. 99% of them communicated adequately, and 98% of them had adequate pacing capture and defibrillation thresholds. So this is sitting on the FDA's desk right now, so we should hopefully have this device before hopefully too long. So thank you very much.